Hello everybody, and a very warm welcome to our webinar tonight on sailing through the menopause. Now this is a part of our 2026 webinar series, which is a series of practitioner webinars designed to give you the tools to deal with a wide range of people in clinic. Now before we begin, I want to go through a few housekeeping rules. So these are practitioner webinars and designed for practitioners and students of nutrition, natural health, natural medicine, pharmacy, or medicine. So if you're not a professional or student of one of these fields, please do log off now. Now, we will be having a question and answer session at the end, so do feel free to add in your questions into the chat box and we will get to them at the end. And also, just a note before we get going, don't forget to regularly check the DR.VEGAN professionals page, where we will regularly updating it with the latest information, handouts, professional guidance, and on-demand webinars. We also have some brand new abstracts that are uploaded. So they're a really great resource for professionals. It talks about all the research. And there's some really great things that you can look up on there. So do make sure you go and check those out. And also, if you haven't already done so, please do sign up for our practitioner scheme. You can get discounts, commissions, free products. And we also have our professional guides on there. You can find all of the research, drug nutrient interactions for all of our products as well. So they're really handy clinic tools. And we also have a great opportunity for practitioners at the moment where you can review a formula of a product in your professional capacity. And you will receive that product for free as a thank you. And there are so many products you can choose from. So it's a great way to try out our supplements, have a really good look at the formula, and get to know DR.VEGAN products much better in your hand and in your home. Okay, so without further ado, I'm going to introduce you to myself and Sue. So I'm Ella. I'm the professional lead at DR.VEGAN, and I'm here to ensure that practitioners like yourselves have the resources that you need to deal with clients in clinic. And we also have our very own Sue on today. So Sue is our nutritionist at DR.VEGAN. Hi Sue, do you want to introduce yourself and tell everybody a little bit about yourself?
How long have you got? Hi everyone, I'm Sue Porchita, and I have nutritional, being a nutritionist and a naturopath is my 5th career in my life, and it's one that I absolutely love. So I currently live in South Africa, but work remotely, which is great. I'm currently on holiday in the UK, so it's nice to see everybody in the flesh, as it were.
Fabulous. Well, thanks for that introduction, Sue. And you've been with DR.VEGAN pretty much since the beginning, haven't you? So
yeah, I'm just part of the furniture now.
Yeah. Okay, so today we're going to look through a range of topics related to menopause. So the first one's going to be menopause through the ages. What exactly is menopause from a biological, biochemical point of view? The latest menopause research, symptom phenotyping, symptom clusters and red flags, again, which is really important to understand red flags if you see them in clinic and refer on. Evidence-based interventions, social considerations, and why it all matters clinically as well. And then finally, we're going to have some key take-homes for practitioners. So, Sue, without further ado, let's go over to you.
Okay, thank you, Ella, and thank you, everyone. It's lovely to be with you today. Menopause care is evolving quickly, and as nutrition and lifestyle practitioners, we are increasingly on the front line. Many people, many women feel unheard in medical settings, and they turn to us for clarity, validation, and practical support. And so today I'm going to give you a deeper clinical understanding of what's actually happening physiologically, why symptoms vary so widely from woman to woman, and how we can build safe, evidence-informed strategies that complement medical care. My aim is to give you a framework that you can use immediately. So how to assess, how to recognize patterns, how to support metabolic, mental, and physical well-being, and where the boundaries lie for our profession. So I'm going to start by grounding ourselves in the physiology, as it were. Now, menopause through the ages. And this is very interesting, particularly with my own experience of menopause. there comes a time in every woman's life when her body begins to change as she heads into menopause. Now, not so long ago, menopause was seen as one of the natural rites of passage, part of the journey through womanhood, something to celebrate and not to dread. But in today's modern world, there are thousands of blogs about the subject due to the numerous problems experienced by so many. One of the most detailed studies of the effects of culture on menopause, which you may already have heard of, involved rural Mayans. And what they found was that although their hormone patterns were identical to postmenopausal women in the United States, the Mayan women experienced no symptoms. And so the researchers felt that the Mayan attitude to menopause was responsible for their symptomless passage. In other words, they saw it as a positive event, bringing with it greater respect. And one of the things that I do, particularly with clients, is because menopause comes with such a negative name tag, as it were, because they're not heard either at work or in the family, is to flip the narrative and to say, let's look at this from what you've achieved in these 40, 50 or 60 years of your life. And let's celebrate that as a woman, that your body has gone through month after month of menstruation, that maybe you have had to have fertility treatment, maybe you've had miscarriages, or you've had a number of children. And these bodies that we live in are absolutely incredible. And so my encouragement to a woman who comes is, firstly, let me flip the script for her. Let me share with her how we honor this transition, this rite of passage that actually can be a time of great joy. We become older, we're wiser, we have life experience. And so I firstly frame it with this whole positive attitude. So this cultural framing of menopause as positive and empowering appears to be protective, whereas in contrast, modern women often experience menopause in the context of chronic stress, disrupted circadian rhythms, metabolic strain, alongside this negative narrative. And I believe that how menopause is perceived really matters. Now, there's also been quite a number of generational shifts. In my family, there's 3 generations. There's my mother, myself, and my daughter. Now, my mother, when I was 15, suddenly this angry woman appeared in my life, and I didn't recognize her. I'm like, who is this woman? She was already born under Scorpio, so she had a sting in her tail and would use it with me. But suddenly I felt completely like a fish out of water with her. And of course, in her generation, these things weren't talked about. And so she didn't prepare me for menopause. She didn't prepare me for starting my periods. When I started my periods, I thought that I was bleeding to death. But we never were able to talk about things like that. So I just had to get on with it. So she went through I think a real roller coaster of a ride, if I think about it, during menopause. Now, I was a little more prepared, but not a lot. But I ended up going through surgical menopause at 40 because I had a massive fibroid, which leant backwards, caused my womb to shift backwards and to fix itself to my bowel. And so I had to have a full hysterectomy. I was in hospital for 10 days. And then I slammed into menopause, put on HRT, which was on for 8 years. And then I had a massive, apparently cardiovascular event, which looked and felt like a heart attack. When they got me into hospital, there was no activity in the heart. And it turned out that it was as a result of the HRT, because I'd moved nations and the communication about what I was on and what they put me on was incorrect. And so, whereas I think HRT is great for some women, for me, it was not. And so I came off it immediately and took control of my hormonal symptoms through diet alone and cutting out stimulants like alcohol and sugar and coffee and those kinds of things. So for myself, it was almost worse than my mum's. But my daughter is growing up in an environment where she also studied nutrition. She now has me as a role model, that it's something to be celebrated. So she's, I'm sure, going to go, when she hits perimenopause, is going to look at it in a completely different way. And I think that will help her going forward. Can we go to the next slide, please, Ella? Slide 5. So what is menopause? Just as a recap, menopause occurs when the ovaries spontaneously fail to produce the hormones estrogen and progesterone, or through medical intervention, such as a full hysterectomy, or when the ovaries are removed surgically, as in an oophorectomy. And it can also stop during treatments such as chemo and radiotherapy. And the lowering levels of hormones, especially estrogen, are the cause of menopausal symptoms in women. The average age, apparently, is 51 years old, but of course it can occur earlier or later. Now, every woman is born with a certain number of eggs in her ovaries, and these are used up through menstruation and childbearing, and gradually the body moves naturally towards the end of a woman's fertile years. So when there've been no periods for 12 consecutive months, a woman is said to be in menopause. How a woman goes through menopause is, of course, unique to her. And some women sail through, whilst others suffer the whole raft of symptoms, ranging from hot flushes, night sweats, mood swings, weight gain, and fatigue. Slide 6, please, Ella. Now, what are the key hormonal shifts? Well, estrogen decline is central to this. Estradiol influences thermoregulation, serotonin, GABA, lipid metabolism, bone turnover, the vaginal microbiome, and collagen synthesis. And as it fails, these systems lose their stabilizing influence. Now, progesterone drops earlier and often more dramatically in perimenopause. And because progesterone supports GABAergic tone, this change explains why so many women experience new or maybe intensified anxiety, poor sleep, heightened stress reactivity years before their periods finally stop. Now, androgens decline more gradually, but they contribute to a loss of a libido, a loss of muscle mass, sarcopenia, resilience, and mood. And SHBG levels shift with metabolic health, thyroid status, and medications, which can influence the bioavailability of what hormones remain. And these hormonal changes reverberate across every system. So understanding this interconnectedness helps to explain why menopausal symptoms feel so diffuse and so unpredictable. Next slide, please, Ella. So what are the symptoms affected? Now, what I've put down here is vasomotor stability, the brain, metabolic, urogenital and pelvic tissues, and bone. Because menopause is a systems level transition. Estrogen withdrawal alters hypothalamic temperature regulation. It narrows the thermoneutral zone and it drives hot flushes. Now, inside the hypothalamus is a group of specialized nerve cells called KNDY neurons. And so these neurons help to regulate reproductive hormones, but also body temperature. And when those estrogen levels begin to fluctuate and decline during menopause, these KNDY neurons become far more active. And so they send stronger signals to the thermostat. As a result, the body's thermoneutral zone becomes narrower. And the thermoneutral zone is the range of temperatures in which your body feels comfortable and doesn't need to cool itself down by sweating or warm itself up by shivering. And that's one of the things that women do comment on, is that they are very sensitive to the slightest changes in temperature. Now, brain neurotransmitter changes explain mood vulnerability and cognitive issues, whilst metabolic, urinary, reproductive, and skeletal systems all undergo rapid change. Dyspareunia, or painful intercourse can have a devastating effect on a relationship. The next slide, please, Ella, slide 8. So I looked at what is the latest menopause research, and there appears to be quite a paradigm shift. And it's happened over the last few years, and it has direct relevance for us as practitioners in our assessment, communication, and management of menopausal clients. So there's a few large cohort studies. For example, SWAN. Now that's the study of women's health across the nation in the USA. We've got the UK Biobank, and we've also got the Australian Longitudinal Study on Women's Health, also known as ALSWH. And they consistently identify reproducible symptom clusters or symptom phenotyping. Now, symptom phenotyping refers to identifying observable, distinct, reproducible symptom patterns, also known as clusters, across the menopausal transition, rather than treating menopause as a single uniform experience. So, recent research shows that symptoms do not appear randomly. They cluster by stage, biology, and trajectory, and different phenotypes likely reflect different underlying mechanisms. So this moves us away from a very simple view of, well, menopause is hot flushes and low estrogen, towards multiple menopausal phenotypes with distinct neuroendocrine, metabolic, inflammatory, and psychosocial drivers. Next slide, please, Ella. Okay, let's have a look at these cohorts at the moment. These are the most influential ones. So the SWAN, which is the USA one, that began in 1996. It is ongoing still. Approximately 3,300 women, multi-ethnic, so that's white, black, Chinese, Japanese, Hispanic, and a longitudinal follow-up across pre, peri, and post-menopause. And as a result of the SWAN study, severe or persistent hot flushes are now considered potential cardiometabolic risk factors or markers, and not just quality of life symptoms. The Australian longitudinal study on women's health also began in 1996, and it looked at 58,000 women. And it supports the neuropsychological menopause phenotype, especially relevant for us as nutrition and lifestyle practitioners, because some women have severe mood and cognitive symptoms and really very minimal VMS, vasomotor symptoms. Next slide, please, Ella. So what are these symptom clusters that they have observed in these large cohorts? We have vasomotor, neurocognitive, mood, genitourinary syndrome of menopause, otherwise known as GSM, musculoskeletal, and metabolic. So when group symptoms into clusters, pattern recognition becomes easier, and we can create more coherent interventions. One of my skills is actual pattern recognition. So this is right up my street when I found these studies. And it's really, really interesting to see what the clusters actually show us. So the first cluster is this vasomotor instability, where you get the hot flushes, the night sweats, the temperature swings. And as I mentioned before, these relate to the changes in the KNDY neurons, which narrow that thermonutrial zone. And that's why women become hypersensitive to tiny temperature shifts, but get the hot face, the red face, wanting to strip off, and then they feel cold again. So it's these hypersensitivities. The second cluster is the neurocognitive and mood-related symptoms. So those would include brain fog, memory lapses, anxiety, irritability. And these are deeply tied to estrogen and progesterone's influence on the brain, on the neurotransmitters. Thirdly, we have the genitourinary syndrome of menopause, or GSM, which would include vaginal dryness, pain on intercourse, recurrent UTIs, And these symptoms are chronic. They're progressive and incredibly common, yet really often undertreated. Then we have the musculoskeletal changes, so the joint aches, the decline in collagen, and faster muscle loss or sarcopenia. And then finally, metabolic changes, shifts in body composition with increasing visceral fat, the menopause belly, and reduced insulin sensitivity. However, alongside this, we really do need to be alert to any red flags. So they would be abnormal vaginal bleeding, chest pain, neurological symptoms, sudden weight loss, signs of thyroid disease, and these women need medical evaluation. Next slide, please, Ella. So yes, these red flags that require referral would be abnormal bleeding, suspected thyroid disease or pituitary issues, cardiovascular symptoms like palpitations or shortness of breath, something that's more severe than normal, severe mood disturbance like suicidal tendencies or severe depression, recurrent UTIs with systemic symptoms, and then rapid unexplained weight loss or pain. These need referring to a medical practitioner immediately. We can always come back and support later on, but we need to make sure that there's no underlying serious medical issues going on. Then on to the next slide, please, Ella. Now, interestingly enough, the latest research also indicates that the timing of menopause, in other words, when menopause starts for a woman, affects cardiometabolic health, especially long-term risks for cardiovascular disease, type 2 diabetes, metabolic syndrome, and mortality. So age at menopause is emerging as an important cardiometabolic risk marker. Early menopause appears to accelerate vascular, metabolic, and inflammatory changes normally buffered by endogenous estrogen. So women who experience what we would call premature menopause, in other words, before the age of 40, or early menopause between age 40 and 45, it's been seen that they have a higher risk of cardiometabolic conditions compared with those who go through menopause at an older age. And a large meta-analysis involving nearly 1 million women found that early or premature menopause was linked to increased risks of the following: type 2 diabetes, hyperlipidemia, so abnormal blood fats, coronary heart disease, stroke, and the total cardiovascular events compared with menopause after age 45. Now, some studies also suggest that women who go through menopause early tend to have more metabolic syndrome. Now, this is the cluster of risk factors such as abdominal obesity, high blood pressure, high triglycerides, low HDL, and high blood glucose. And although it hasn't yet been published in a peer-reviewed journal, I did find a recent metabolic study on menopause involving Dr. Shefali Setia-Verman, which was presented as a conference abstract and reported in scientific news coverage. So metabolic syndrome and diabetes. We've seen that early menopause is linked with a higher prevalence of metabolic syndrome, implying a greater burden of clustered cardiometabolic risk factors. This is potentially due to changes in body fat distribution, insulin resistance, and estrogen deprivation when looking at the increased risk of type 2 diabetes. And in women who already have type 2 diabetes, early menopause may further increase that cardiovascular risk beyond the baseline of diabetes alone. Now, ongoing research is aiming to clarify how structural brain changes relate to specific menopausal symptoms and whether treatments like hormone therapy affect these outcomes. So what are the mechanisms involved? Well, the loss of endogenous estrogen, appears important because estrogen normally helps blood vessels to relax and dilate. Estrogen supports healthy lipid metabolism. It reduces inflammation and oxidative stress, and it also influences insulin sensitivity. So estrogen's decline during menopause accelerates these particular cardiometabolic changes. Next slide, please, Ella. Conversely, late onset menopause reduces long-term cardiometabolic risk. So women who enter menopause later, so age 55 plus, show better vascular function and lower risk of heart attacks and strokes, possibly due to healthier blood vessel and metabolic profiles. Large-scale data analyses show that menopause causes widespread step-like changes across physiology. So that's your hormones, lipid metabolism, inflammation, bone health, with many changes beginning even more than 10 years before final menstruation. Now, we know that HRT may attenuate some of these changes. Next slide, please, Ella. This is really interesting. So the stage-specific symptom patterns. In early menopause, the hormonal feature is that there is raised estradiol variability and preserved average estrogen. And the dominant symptom phenotype, what you find in there, the symptom clusters are cycle shortening and irregularity, PMS-like symptoms, breast tenderness, migraine flares, anxiety, irritability, and interestingly, sleep disturbance without classic vasomotor symptoms. So the mechanism for this is rapid estrogen fluctuation leads to neuroendocrine instability, and progesterone decline often precedes estrogen decline. So the key insight from this particular symptom cluster is that many women are highly symptomatic before estrogen levels fall meaningfully. And that's where testing plays a part, because even if, for example, a Dutch test tells you one thing, if we're aware of these symptom clusters, we can actually think ahead, if you like, and prepare a client for what may come. Slide 15, please, Ella. Then if we look at late menopause, the hormonal feature here is that the estradiol drops and we get an increase in the anovulatory cycles. So more months where there isn't a period. Maybe there's 1 month, maybe there's 3 months, maybe there's 6 months. And so that's one of the typical features of late perimenopause. What they found, the dominant symptom phenotype, what it included was these vasomotor symptoms, night sweats, sleep fragmentation, brain fog, mood issues, and fatigue. So the mechanism behind this is estrogen withdrawal, or a more of a reduction in estrogen, affects hypothalamic thermoregulation via the KYND neurons, as I spoke about. The mechanism is also due to altered serotonin, norepinephrine, and GABA signaling. And there's been a research shift with regards to this. So VMS, so vascular motor symptoms, are now understood as central nervous system phenomena and not just vascular, not just related to quality of life. Next slide, please, Ella. Then if we move on to the early menopause, so 0 to 5 years after that, they've done the 12 months consistently of no periods, what we see as the hormonal feature is sustained hypoestrogenism, so consistently low levels of estrogen. Now, the dominant symptom phenotype here is that vasomotor symptoms are at their peak. They're most severe. Plus, we have the genitourinary syndrome of menopause, the GSM, joint pain and stiffness, reduced stress resilience, and sleep and mood disorders. So the mechanism of this is the loss of the anti-inflammatory and neuromodulatory roles of estrogen because it's consistently low. So therefore, the anti-inflammatory role, the neuromodulatory roles are also lowered. And there's also a structural and functional brain adaptation underway. The important thing to take away from this slide is that for many women, this is the highest symptom burden window. So in other words, 0 to 5 years after the 12 months. Next slide, please, Ella. And then if we look at late post-menopause, here we find stable low estrogen. Everything's kind of settled down. Although the dominant symptom phenotype found that there were fewer VMS for most, but there was now persistent GSM, so the more of the genitourinary issues. There was also cardiometabolic symptoms and cognitive complaints, such as not being able to think as fast, so processing speed and recall the word that's just beyond, and also musculoskeletal pain. The mechanism here is that there are long-term metabolic, vascular, and inflammatory effects. And it's where aging and estrogen deprivation interact together at causing these issues. Next slide, please, Ella. So let's look at these symptom clusters that have been identified in recent research. In the neuropsychological phenotype, we find anxiety, depression, irritability, brain fog, sleep disturbance. And these symptoms often appear early. They often occur without severe VMS, and they're strongly linked to the stress axis, the HPA axis, trauma history, and sleep disruption. Trauma history could also include ACEs, advanced childhood experiences, when there's been maybe abuse as a child. Moving house often can cause loss of security. Sexual abuse can cause loss of sexual security. And so these things can suddenly surface at this time in a woman's life because everything is on a roller coaster. Then we have the vasomotor dominant phenotype, and this is where we find the severe hot flushes, night sweats, palpitations, sleep disruption. These are associated with a higher cardiometabolic risk, greater inflammation, and worse endothelial function. And as I mentioned before, VMS severity is now considered a potential cardiometabolic risk marker and not just a quality of life issue. So we really need to be looking at this and taking note. Next slide, please, Ella. The somatic musculoskeletal phenotype, these symptom clusters, we have joint pain, myalgias, reduced recovery after exercise, and fatigue, which often overlaps with sleep disturbance, insulin resistance, inflammatory markers. The metabolic inflammatory phenotype is seen as central weight gain, dyslipidemia, rising glucose levels, fatigue, brain fog. And these are more common in early menopause and in women with early or surgical menopause. Next slide, please, Ella. So some evidence-based interventions, early intervention focusing on healthy lifestyle habits. So physical activity, diet, weight management, early screening for metabolic risk, careful management of blood pressure, either through diet, looking at lipids, so cholesterol, making sure that our clients understand the role of cholesterol in the body as we get older, and also glucose levels and the importance of exercise, liver health, and all those kinds of things. They may help to offset long-term cardiometabolic risks. So slide 21, please, Ella. What core dietary strategies can we... Oh, okay. I thought I'd change this slide. Sorry about that, everyone. I did put it in the core dietary strategies. They're ones that we all know really well, but I did want to go through them. So the Mediterranean style diet is consistently associated with reduced vasomotor symptoms, improved cardiometabolic risk, and lower bone loss. Phytoestrogen-rich foods such as soy, flax, legumes, modest but reliable improvements in hot flushes for many women. Protein optimization to counter sarcopenia and support mood and metabolic health. Color-rich plants and polyphenols to modulate inflammation and oxidative stress. Stable glycemic patterns to reduce flush severity and energy crashes. And then limiting alcohol and ultra-processed foods, which have strong links with vasomotor symptom severity and sleep disruption. And we know that nutrition is one of the most powerful tools we have during menopause. Going back to the Mediterranean style way of eating, it consistently shows benefits because of the fiber, the antioxidants, and the healthy fats that help to calm systemic inflammation, which often amplifies menopausal complaints. The phytoestrogen-rich foods offer very gentle estrogenic activity through the ER beta receptors. Now, they don't function like HRT, but they can smooth symptoms for a subset of women and provide cardiometabolic benefits. Many menopausal women suddenly start exercising because they feel they're at that age where they need to. And so protein needs often increase, and an awareness of that is often lacking, particularly when there's accelerated muscle loss if they're not exercising, and with the changes in insulin sensitivity. Most women will thrive on 1 to 1.2 grams of protein per kilo body weight per day. If they are exercising, doing resistance training, strength training, then they may need more. Adequate protein, of course, supports satiety, balances blood sugar, stabilizes energy levels, thermogenesis, muscle retention, and stabilizes mood. And stable glycemic control is crucial. Maybe low GI, eating in a low GI way, because blood sugar dips can trigger or worsen hot flushes, sleep disruption, and irritability. And of course, evening alcohol is another major driver of night sweats and fragmented sleep. So really what we're looking for here is small, consistent dietary adjustments, which often produce meaningful improvements. For myself, when I'm working with menopausal clients, I will often give them, depending on how severe their symptoms are, how stressed they are, how busy they are, I may often give them just one thing to do. And they'll say to me, "Are you only giving me one thing?" And I'm like, "Yes, let's start. Let's go low and slow. Let's start with something that I see as the priority. Maybe it's to reduce inflammation. Maybe it's to remove ultra-processed foods. But I always have felt that adding in healthy rather than removing unhealthy is less of a stress, because we know that when you start to introduce healthier foods, that our you see, there we go. The word has just gone. The things that are in our tongue. Ella, what are they?
What reduces junk food and inflammation?
No. Our what are those things in our taste buds? Taste buds. There we go. Okay, Ella's just had a baby not so long ago, so she's still got baby brain, and I'm postmenopausal, so I was needing some omega-3. But we know that healthy foods, when you remove those ultra-processed, high sugar, high carb foods, that your taste buds change. And so you no longer crave those unhealthy foods. And so I will also maybe do 1 or 2, maybe 3 tops with menopausal clients, just to mean that they're going to be more consistent. And it does seem to work. Next slide, please, Ella. So looking at lifestyle. As a naturopathic nutritional therapist, I always look at lifestyle when I am dealing with a client, excuse me. Lifestyle interventions are where we see some of the most profound improvements, and exercise is foundational. Resistance training 2 to 3 times per week helps to preserve muscle, improve insulin sensitivity, reduces central adiposity, supports mood, and protects bone density. And adding moderate cardio, complements these benefits, especially for vasomotor stability. Sleep hygiene, I'm sure you all know about sleep hygiene. Sleep becomes more fragile in menopause. And so a combination of cooler bedroom temperatures, maybe more natural fabrics for sleeping in and for sleeping under, consistent routines, turning screens off an hour before bed, etc., and reducing evening stimulants does make a tangible difference. Simple behavioral sleep strategies often work better than supplements. We know that stress physiology shifts during menopause. Declining hormonal buffer of estrogen means women become more sensitive to cortisol fluctuations. And so practices such as paced breathing, mindfulness, and regular restorative activity like grounding, getting out into nature, reduce vasomotor intensity and improve resilience. Pelvic floor health, pelvic floor work is another pillar. Particularly working in collaboration with physiotherapists can drastically improve continence, sexual comfort, and confidence, and which is vital for a menopausal woman. So the core message is that lifestyle isn't just supportive, it's physiologically corrective. Next slide, please, Ella. Special considerations. I'm just going to briefly touch on this. So not all menopause journeys are the same as with mine. Women experiencing surgical menopause, for example, after oophorectomy or a full hysterectomy, lose hormones abruptly, and symptoms tend to be more intense and wide-ranging. So these women always need a more structured, multidisciplinary approach. They need a listening ear, because going through full hysterectomy can affect their identity as a woman, and it can be a very emotional time. So we do need to listen to what they're going through and help them in a greater way in some ways. Early menopause and then primary ovarian insufficiency also require gentle handling, because these women face fertility considerations, higher cardiovascular risk, and long-term bone health implications. And they may also experience a profound sense of loss, particularly if they are unable to have children and have, for example, idiopathic infertility. And I think we should finally acknowledge the social and cultural context. Many women have internalized a narrative or a sense that they should just cope. They should just get on with it. It's part of being a woman. Others experience dismissal in clinic settings. Being heard and being validated is often as therapeutic as any intervention. Now, there are some updated clinical guidelines that were published in 2025 for managing menopause and perimenopause, endorsed by major European and international societies. And these emphasize comprehensive evaluation of symptoms, staging, as in the symptom clusters, etc., and individualized therapy. And then slide 24, why does this matter clinically? Well, many symptomatic women are missed because they're still menstruating, their symptoms are not classic hot flushes, and so phenotyping improves the recognition of perimenopause and not just menopause. So slide 25, what are the key take-homes for practitioner? Firstly, menopausal symptoms cluster predictably. Perimenopause is often underrecognized but highly symptomatic. Vasomotor symptoms may signal future cardiometabolic risk, and better phenotyping equals better validation, earlier intervention, and more precise care. Thank you.
Thank you so much, Sue. That was really, really interesting. I hope everybody learned a lot from that and feels more equipped to deal with menopause, perimenopause, and postmenopausal women in clinic. Now, as you can see on the screen, we have a wide range of products which may actually be helpful to women who are perimenopausal, menopausal, postmenopausal, depending on kind of what their symptom set is and how their body's dealing with it. So obviously we've got here, they've got the MenoFriend and the PeriMenoFriend. So I'm going to talk more in depth about the MenoFriend in a minute. But do have a look at both the MenoFriend and the PeriMenoFriend, because there are some slight differences in between those. So do have a look at the differences there. Magnesium glycinate is obviously a fantastic one for women who have sleeping issues, want to relax a little bit more, kind of feel a bit stressed. Magnesium also helps with the regulation of hormones. So that's a great one to add in. And of course, omega-3, so that helps with the cellular binding of estrogen and progesterone. So even though your hormones are dropped, you can make the most of the hormones that you do have. Omega-3 obviously is needed to reduce inflammation as well, which excess inflammation is a problem in menopausal women. And glucobalance, so those women that are having elevated glucose levels, crashes throughout the day, this is a great one to consider. We also have our weight management support, so any women that have gained a little bit of weight during menopause, finding it really tough to lose it, with a really healthy diet, add this supplement in and it makes quite a big difference. So there's some good studies on that, so make sure you do go ahead and read that the paper on that and look at the research. Okay, we've got the OsteoFriend. So obviously a lot of menopausal women are concerned about bone health, and listen, this is a really good product. It is one of the best out there on the market. It's got 19 different ingredients, everything you need for bones, so even down to things like making sure you've got the right bacteria in your gut to then support bone stability. We've got the protein and creatine super blends, again, so supporting those muscles in women, and of course creatine is fantastic also for the brain as well as the muscles. So if you feel like you've got a woman in clinic who could do with some support for her brain, then do try this one out as well. The creatine is going to be really helpful there. And next to that, we've got the creatine and branched chain amino acids. Again, really great for women that want to, kind of really support their muscle health. And finally, we've got gut work. So the gut microbiome can change. And the fantastic thing about gut works is it doesn't just help the gut, it helps also the vagina and those tissues down there. And that may help to protect against things like recurrent urinary tract infections and other infections that menopausal women might have going on down there. So now I'm just going to talk about MenoFriend because obviously we haven't got time to go through all of those products. So as you can see, looking at these ingredients, you've got a whole range of phytoestrogens in there. I will go through those ingredients one by one in just a moment, but I just want you to have a look at that entire ingredient list. We're supporting the phytoestrogens intake. We're also supporting the way that the cells receive those phytoestrogens and the estrogen that is in the body. You've got a maca root, which is fantastic for things like libido, energy, and magnesium for helping to keep calm, and obviously magnesium and calcium for the bones. Selenium to help with antioxidant effects and also to support the thyroid gland. And you've got your B vitamins in there, so you've got B6, B2, B3, B5, K2, and D3 as well. So a really good all-round product. We have a lot of good evidence and research on those individual ingredients, so do go and check those out. Okay, so for the first ingredient, I want to talk about wild yam. Now, wild yam specifically is a significant source of dioxygen, and steroidal sapins, and they have phytoestrogenic properties. And these compounds increase the affinity for estradiol and estrogen receptors, particularly estrogen receptor beta. Now, if you remember estrogen receptor beta, because later on we're going to talk about estrogen receptor alpha, and it will kind of work, the puzzle we put together in your mind as to how they work in a holistic way. So estrogen receptor beta, that's the one that wild yam supports. Wild yam is also neuroprotective and antioxidant. And research does show that it can reverse anxiety and depression and also improve cognitive impairment. So can also normalize high cortisol levels as well, and also support cognitive function as a whole. So if you have got any women that are particularly worried about their brain, wild yam, is a really good ingredient for them. Okay, so we've also got dandelion root in here, and of course, not only is it very rich in vitamins and minerals, it's also got other compounds in there like flavonoids, phenolenic compounds, and these upregulate hormone receptors and influence estrogen metabolism, and also improves the body's response to estrogen. So when you have got a lowered amount of hormones, it's really important to kind of maximize those and make the most of them, to help kind of decrease the symptoms and help you feel a little bit better. So the bioactive compounds in dandelion, they also inhibit pro-inflammatory cytokines. And when you're decreasing inflammation, you're also improving things like immobility and joint discomfort, which quite a lot of women do suffer from, unfortunately. Okay, so we've got mung beans in here as well, which is actually really quite an unusual ingredient for a menopause product, but actually it's in here for a very good reason. So it's very rich in bioactive phytoestrogen compounds, flavonoids, isoflavones, and phenolenic acids. And they all have hormone modulating antioxidant properties. And actually they contain 19 neuroprotective polyphenols and promote autophagy and acetylcholinesterase enzyme activity. So they're also cardioprotective. They help to regulate cholesterol levels and help to maintain cardiovascular epithelial function. On top of that, they also help to support and regulate insulin levels, glucose metabolism, which, as I mentioned earlier, can be negatively affected by hormones, that drop in hormones that you have in perimenopause and menopause. Okay, sage, most of you would know quite a lot about sage for menopause. It is one of those really common ones for reducing hot flushes. It has a unique composition of bioactive compounds, and it acts through several mechanisms. So the compounds are phytoestrogenic, and they bind to estrogen receptors, and it's been shown to be particularly beneficial in the thermoregulatory centers and the control centers of the brain, the temperature control centers of the brain. So it actually does help to reduce hot flushes and night sweats. And again, make sure you go and have a look at the research on that. It's all on our practitioner papers, which is on our professionals website. Really good thing to have a read of. In addition, sage also has been shown to inhibit acetylcholinesterase activity. So that leads to increased acetylcholine, and that, of course, is protective of memory function and learning. So if you've got any women that are trying to power through their job, great ingredient to have. Sage also influences GABA as well, and promotes a sense of calmness, reduction in anxiety and irritability. Dong Quai, okay, Dong Quai root contains curcumins, ferulic acid, and flavonoids, and these, of course, also have phytoestrogenic properties. Ferulic acid is a key active compound for vasodilatory properties, so it helps with the vasodilation, and actually, contrary to what you might think, that doesn't increase hot flushes. Actually, that decreases hot flushes. Because when you get those hot flushes, you're getting that sudden increase and decrease in vasodilation that's causing those. But when you're kind of supporting that vasodilation, you're supporting adequate blood flow, and you're not getting so much fluctuations in there. Okay, so it also helps to modulate levels of luteinizing hormone and follicle stimulating hormone, which become dysregulated during menopause. And the body attempts to overcompensate for reduced ovarian function, so that's why your FH and FSH and LH become disorientated. And finally, ferulic acid also inhibits bone reabsorption and supports osteoblast activity, contributing to better bone health. So it's not all about calcium and magnesium for bone health. You've got to look at the phytoestrogens as well. Hop extract. Okay, so again, hop extract is rich in phytoestrogens, and particularly something called 8-prenylnaringenin, if I said that properly. It's a bit of a mouthful. 8-PN, and that's responsible for its beneficial effects, and it's particularly good at binding to estrogen receptor alpha. And that's a subtype of receptors that are found in the uterus, in the breast, in the bones, and in the brain. And it has a strong affinity for estrogen receptors and helps to alleviate vasomotor instability. So if you look at the whole combination, you're supporting estrogen receptors alpha and beta. So hop extract also helps to stabilize fluctuations on the estrogen receptor alpha receptor, reduces the severity of hot flushes and night sweats, and also quite sedating and quite mood stabilizing as well. So it does encourage GABA production, again, which improves anxiety and helps with sleep. And when you've had a good night's sleep, you can take on the world. It helps even menopausal women. Okay, so red clover. So red clover, again, has a high content of phytoestrogenic isoflavones, which bind to estrogen receptor beta. So these specifically are 4-monontin, biochanin A, and diazine and genistein. And red clover works on the hypothalamus to regulate the body temperature and help stabilize temperature fluctuations. Its isoflavones also help to prevent bone loss by stimulating osteoblast activity, by supporting bone density and reducing the risk of fractures. And a meta-analysis and systemic review concluded that phytoestrogens, like those found in red clover, reduce the frequency of hot flushes without the side effects that can be experienced with conventional HRT. So it has a very similar effect, beneficial effects to HRT, but without those negative side effects. Okay, so we have on here maca. And maca root contains sterols, macamines, prostaglandins, and these can influence the hypothalamic pituitary adrenal axis. And that then regulates a hormonal balance, regulates adrenaline, cortisol, and also thyroid hormones as well. And because it's adaptogenic, it's very good at enhancing the body's ability to respond to hormone fluctuations. So rather than working directly on the estrogen receptors, maca works in a different way, but also has beneficial effects for menopausal women. And of course, one of the most well-known effects of maca really is its ability to improve libido and sexual function in menopausal women. So maca acts on the dopaminergic system and increases the release of dopamine, and that's a very important neurotransmitter for sexual desire. Maca improves vaginal dryness, low energy levels, and again, these are two factors that also contribute to reduced sexual function during menopause. So if you're finding a loss of libido, make sure you're getting your maca. Kelp. So this is rich in iodine as well as many other minerals and antioxidants, which can be helpful for managing menopause symptoms. So when you're going through the menopause, you really need to keep the thyroid function working adequately. Any fluctuations in thyroid function can further add to the symptoms of menopause. So you want to keep it working healthy to prevent things like fatigue, weight gain, and also depression. These are all symptoms of low and under-functioning thyroid. And when, as you know, in the body, all the hormones play together. So it's really essential that this is one of the things that you do look at. Okay, so magnesium and calcium. Magnesium, as I mentioned earlier, is really important for hormonal regulation, bone health, nervous system function, and also metabolic processes. It's needed for over 300 processes, biological processes in the body. And also calcium is essential for bone health, muscle function, nerve transmission, and also plays an important role in general well-being during the menopause. So that's why we've added those two in there. Selenium. So selenium is an essential component for selenoproteins, and that's a key antioxidant enzyme needed for glutathione peroxidase. And glutathione peroxidase helps to neutralize harmful free radicals, and which contribute towards oxidative stress. So one of the things that Sue mentioned was, really bringing down inflammation. So selenium can help you do that by contributing to things like glutathione peroxidase. It's also essential for thyroid hormones as well, normal function of the thyroid gland. Also needed for the immune response. And unfortunately, menopausal women, or women that are having menopause symptoms, perimenopause symptoms, can see a reduction in immune system function. Selenium does help to support things like T cells, natural killer cells, so it's really important to kind of maintain that minimum level of immune system function. Okay, B vitamins. I'm not going to go through them all individually because we will be here all day. But B vitamins as a whole, they have a hugely essential role in psychological functions. Even hormone production, the production of things like serotonin and then melatonin, energy metabolism, cognitive function, mood regulation, and overall hormone balance as well, adrenal function, progesterone creation. I'm sure you know what kind of B vitamins do within the body. Vitamin B6 and B12 also help to contribute to normal homocysteine levels. You want to make sure that your menopausal women don't have too high homocysteine either. As well as being important things like brain function, cognitive function. So really important that you do get those B vitamins into your menopausal women. And finally, we've got vitamin D3 and K2. And as you know, these are essential for bone health and also cardiovascular function, as well as overall well-being. So everyone knows that vitamin D3 is essential for calcium absorption through the gut and helping to maintain adequate serum calcium levels. Again, which is essential for bone mineralization. And K2 activates the proteins that help bind calcium to the bone matrix, and that promotes bone density. The activation of the matrix of GLA proteins by K2 helps to prevent arterial calcification and promotes bone health. And helping to prevent arterial calcification is essential because post-menopause, women are at higher risk of cardiovascular issues. So making sure that you're getting your K2 in there as well as your D3. Okay, so the references here and here and here. So if you would like those emailed to you, do drop me an email and I'll send them on to you. Thanks for listening. And before we go, we're going to have a look at the questions. So
there's a couple that have come in, Ella.
Yeah, if you can see them, feel free to start answering, Sue.
Well, firstly, one from Irina is, hello, will we get the access to the slides, please? And that's a yes.
Yes. So it will be on demand. Okay, so just wait a couple of days, it'll be on demand. If you don't get access to the slides directly, just email me, ella@drvegan.com, and I can send them to you. That's not a problem.
Okay, the second one is, how can we help a woman who's been on birth control, has had no periods for years, and thinks she's experiencing menopause? Lily, I think that this system phenotyping, these system clusters, can really help if you're aware of, the different stages that I took you through. Just the fact that she hasn't had periods, you can have a look at the other symptom clusters that are there, and then look at the pattern. Is she perimenopausal? Where is she? Is she in early or later perimenopause? And I think this pattern, looking at patterns, is going to be really, really helpful. I also think that one of the things that's been overlooked with hormonal menopausal women is nervous system regulation. Many women come into this time of their lives and they're carrying some kind of nervous system dysregulation. They may have had bereavement. They may have had high stress from work. They may have gone through divorce. They may have had some kind of financial loss. And so, and they may also, particularly menopausal women, you know, move into that age when parents are becoming elderly, and then we end up being caregivers. And that's a massive stress on top of everything that's going on. So I think we need to be really aware of, for example, rather than saying what hormones are changing in a client, is to ask, how safe and regulated does this woman's body feel? And if so, to use something like vagus nerve reset, you know, breathing, cold water on the face, singing, humming, all those kinds of things to reset, box breathing, because otherwise that's just a double whammy on top of everything. And then also there was another one that came in about how do you distinguish between normal menopausal changes and signs where deeper support or referral is needed. And I think a good starting point is that we need to validate a woman's experience without just saying, well, it's just menopause, which of course is what they will have heard from around them, very possibly. And I think the question that we can ask in this case is this new symptom severe? Is it unexplained? Is it escalating? And is it affecting daily function? And I think that's where we can look into something deeper and work with a team, either a GP or some cognitive behavioral therapy. I often will recommend to my clients tapping, EFT, to break some of these thought patterns and cycles that they get in 7 minutes. And that can really, really help.
Sue, we've also got another question as well on here.
Okay.
So someone's asking about detox and deblight, and is it great for clients to support liver and detoxification for menopausal clients who find or may struggle to process alcohol and sometimes to develop other intolerances such as histamine? Guidance is mixed, contraindicated for milk thistle silymarin for clients on HRT. So what would your opinion be on debloating detox for that?
Well, you know, as working for DR.VEGAN, our advice is always to ask a health practitioner. Now, we know that GPs are very busy these days, but pharmacists have a wealth of knowledge, and so you know, we can't carry all the medications in our brain, if you like. So we do need to lean on the wealth of knowledge that pharmacists have for a particular type of HRT as to whether a herbal formula in particular is suitable. It may be with some, maybe with not, maybe not, but we aren't allowed, obviously, to advise in those ways. So I would always ask my client to contact their local pharmacist, because they're local and they have this wealth of knowledge.
Fabulous, thank you. Okay, I think that's it for questions. I
think it's all we've got time for anyway.
It is, yeah. Thank you so much, Sue. You've been fantastic. Thank you again for everybody listening. Don't forget to join our webinar next month as well. So that will be on a non-alcoholic fatty liver disease with Mark Killick. So do look out for that and register for that. So any questions you think of in the meantime or further on down the line, if you're watching this on demand, do feel free to drop them over to me on an email, ella@drvegan.com, and I will get back to you as soon as possible. Okay, thank you so much, Sue. Once more, you've been fantastic. And again, thank you to everybody who's been listening. Enjoy your evening, everyone.
Thank you. Bye-bye.
Bye.